Dear colleagues, good morning or good day. I'm going to talk about our approaches in limb length and deformity correction in children with abnormal bone. Since 80s of 20th century, our subspecialty of limb lengthening and reconstructive surgery has emerged and proved its relevance. Nowadays, clinical services dedicated to limb reconstruction within an academic department of orthopedic surgery provide excellent surgical outcomes and increase academic productivity, and it's everyday practice. And all this time, the gradual lengthening based on the principles of the Lizarov method remains the most accepted, well-established procedure. I'm going to tell about our approaches in use of combined technique, uniting external fixation and hydroxyapatite-coated flexible intraepidal renailing fin in limb lengthening and deformity correction in children with abnormal bone associated with bone fragility, benign tumors, delayed union, and secondary multiplanar and multi-apical limb deformities. Of course, surgical correction is a part of multidisciplinary treatment in those conditions. There are lots of different operative methods for correction and fixation, as well as complications and problems related to them in our practice, but an internal device left in situ after correction should be considered as the most important element of osteosynthesis in abnormal bone surgery. In our center, we are used to associate external fixation and flexible intraepidal renailing with osteoinductive flexible coating for limb reconstruction associated with compromised bone regeneration. We find the composite piezoelectric layer of 35% copolymer of phenylidene fluoride with tetrafluoroethylene associated with hydroxyapatite as an optimal solution for flexible intraepidal renailing aimed to achieve osteoinductive properties. The polymer external layer with integrated particles of hydroxyapatite provides increased number of cells adhered on the surface of the coating around micropores. Composite copolymer coating is optimal due to its high flexibility, and this coating provides osteoinductive and osteoconductive activity not only due to the active fillet but also due to its rough surface. It was published in several articles. In this talk, I'll demonstrate our results of use of external fixation with titanium or hydroxyapatite coated intraepidal renailing in patients with early disease, polyostotic fibrous dysplasia, and anterolateral bowing of congenital pseudoarthrosis of tibia. You know that multiple enchondromatosis is uncommon on non-hereditary bone disorder. Intervention on the enchondromas seems to be insufficient, but early disease related complications, axial deviation, and limb length discrepancy required reconstructive surgery for correction and lengthening. We have been using this combined technique for bone reconstruction in rare disease since 2004. The surgical procedure itself consists of several steps. For example, for femoral monofocal lengthening, the first step is standard application of external fixator, but first we insert only 2 wires in the distal ring and 2 wires or half pins in the proximal arc or ring. It makes easier insertion of intramedullary nails. The second step is standard, and it's percutaneous osteotomy using conventional technique, percutaneous technique. For intramedullary renailing, 2 entry holes are made at the metaphysis level within an awl in an oblique direction towards the osteotomy site at the distance of 20 to 30 mm from the growth plate. Then 2 precurved nails are inserted through entry holes up to opposite metaphysis one by one, using the handle, for example. If needed, we use a special curved guide with a slot to place into a bent nail to insert it throughout chondromatosis or fibrous lesion following required trajectory. When pathologic tissues are passed, the handle may be used for nail insertion. At the last step, we complete the external fixator, adding some wires and half pins at the level of proximal arcs, middle and distal rings. While the lengthening is in progress, the intermedullary nails gradually move into a diaphysis, sliding through medullary canal and pathologic tissues. After frame removal, intermedullary nails are left in situ for a long follow-up period or for life. As you can see in this case, a girl with Masucci syndrome represents multi-apical deformity of the right lower limb with limb length discrepancy. We performed simultaneous polysegmental lengthening using intramedullary nailing and Elizarov technique. Finally, we achieved planned lengthening with accurate alignment of lower limb, and the total gain was 7 centimeters with healing index of only 14 days per centimeter. Also, conventional external fixator techniques can produce satisfactory distraction osteogenesis in early disease and consolidation. They are associated with relatively high rate of complications, including prolonged healing index and fractures through affected or chondromatosis areas. Combined technique in our series allowed the mean decrease of healing index is about 8 days per every centimeters of lengthening. Another issue of early disease is represented by pathological fracture related to chondromas and bowing. The rate of these complications is about 30%. After deformity correction procedures, the rate of fractures at lengthening site or at chondromatous zone decreases up to 5 to 10%. In our series, we observed no fracture of bones with hydroxyapatite-coated intramedullary nails left in situ after reconstructive surgery. Furthermore, with long-term follow-up of 2 to 5 years, we found no cases of pathologic fracture of abnormal bone with hydroxyapatite-coated intramedullary nails left in situ, like in this case, with a femur with a very compromised bone tissue. So we can draw conclusions that in early disease, intramedullary nailing with hydroxyapatite coating stimulates bone healing and limb lengthening, and thin left in situ prevents both fractures of newly formed bone and pathological fracture in long-term follow-up. Polyostotic fibrous dysplasia consists on a fibrous stroma with mutated fibroblast cells and osteoblasts, which produce abnormal trabecular or woven bone. In polyostotic fibrous dysplasia, pathologic fractures, limb deformity are common. Bone grafting and osteosynthesis with plates are not efficient in weakened bones. We have a series of 8 children where we performed lengthening and deformity correction, associated external fixator, and hydroxyapatite-coated intramedullary nails in 3 cases and titanium nails in 5 cases. As we know from the literature, in limb lengthening with external fixator in fibrous dysplasia, the bone union is always delayed. Tsuchiya and Arlap reported healing index of 51 days per centimeter until 140 days per centimeter. In our series, where we applied combined technique, the average of healing index was only 32.5 days per centimeter, and it's comparable to conventional lengthening in a normal bone. Regarding radioanatomical angle values reflecting achieved correction, the intramedullary nailing maintained alignment throughout follow-up period in 6 cases. Like in this case, in a year after frame removal, there was no limb length discrepancy, no deformity relapse, neither intramedullary nail migration. In a year after frame removal, we noted radiological signs of bone remodeling in fibrous display lesions with osteoconductive flexible intramedullary nailing in 4 cases. You can compare radiographs before lengthening and by 1 year after frame removal at the latest follow-up control. As adverse effects and complications, we faced local pin site infection without sequelae in 3 cases. Fractured lengthening site, we didn't observe this kind of complication. Nice internal migration of nails. Partial deformity relapse was observed only in 2 cases. And according to Loscombe classification, we achieved grade 1 in 7 cases and grade 2B in one cases. So as conclusion, we find advantages of binary technique in management of limb length discrepancy and deformities in patients with polyostotic fibrous dysplasia in reduced external fixation time, high accuracy of alignment related to flexibility of the intramedullary nails and progressive character of Lizarov method for limb length and deformity correction. Intramedullary nails left in situ, especially nails with hydroxyapatite coating, is likely to prevent deformity recurrence and stimulate remodeling in dysplastic fibrous zones. Unfortunately, we did not find this effect for all diseases. Only for fibrous dysplasia, intramedullary nails with hydroxyapatite coating stimulates bone remodeling in pathologic zones. We find indication for combined technique application in children with anterolateral bowing in congenital pseudoarthrosis of tibia. In literature, this kind of deformity in CPT includes non-fractured bowing or residual bowing of tibia. It's often characterized by progressive deformity requiring realignment. Anorthosis may prevent fractures, but spontaneous dressing of tibia cannot be expected. Realignment and bone union without loss of tibial length are objectives of orthopedic surgery in anterolateral bowing. But surgeons very often face delayed or non-union after corrective osteotomy. We have a series of 6 cases of anterolateral bowing treated with the combined technique. 2 children had no surgery before admission in our clinic. 4 patients previously underwent resection of pseudoarthrotic zone and fixation using Lizarov frame associated or not with lengthening. In all cases, Lizarov or Taylor special frame was used in combination with hydroxyapatite coated intramedullary nails. The features of surgical technique were percutaneous osteotomy distal 2 to 3 cm to deformity apex and progressive deformity correction initiated on the 7th to 8th postoperative day. Have a look at this case of a 14-year-old boy with neurofibromatosis type 1. He never had fracture, but anterolateral bone required realignment. Surgery was done with Taylor special frame and retrograde nailing. Osteotomy of tibia was performed at distance of 3 cm from cora, followed by progressive deformity correction. Bone union was achieved in 3 months and we removed Taylor special frame. Remodeling of bone with re-establishment of medullary canal was observed later. It allowed to remove intramedullary nails. The patient is considered to be healed in 2 years after frame removal. This 4-year-old boy was previously operated on with a Lizarov technique, but residual deformity with slowly progressing anterolateral bone were noted and justified a further surgery. Pay attention to narrow and sclerotic medullary canal. Monofocal correction was done applying combination of Lizarov and hydroxyapatite coated intramedullary nails. We did not observe any delayed union. Alignment remained normal in 2 years after surgery. At the latest follow-up control, CT scan demonstrated remodeling of tibial shaft, re-establishment of medullary canal, and formation of dense trabecular structures of cancellous bone tissue around nail without a fibrous tissue layer between. In our series, the mean external fixation time was 95 days. All patients never fractured after frame removal and are considered to be healed without fracture or deformity relapse. In all cases, mechanical axis deviation and radioanatomical angles are within normal value at latest follow-up control. We have a short series of patients with Crawford 4 of CPT treated with combined technique using hydroxyapatite coated nails. In management of CPT, we distinguish mechanical or surgical features and biological ones. Surgical ones are use of external fixator, ensuring realignment, decreasing risk of refracture, long-lasting intramedullary nailing or rodding, maintaining medullary canal open, stability of fibula, and increased cross-sectional diameter of bone obtained by appropriate pathological bone and fibrous hamartoma removal. Biological features aspect is provided by osteoinductive coating of intramedullary nail stimulating bone formation. For example, in this case of CPT Crawford 4, all previous surgery failed. We performed lengthening, simultaneous lengthening, and resection of hamartoma and sclerotic ends of pseudarthrosis. And finally, you see we achieve lengthening and bone union at distal third of the tibial shaft. In a year after frame removal, this patient is considered to be healed. Like some discussion, we find inconveniences using telescoping rodding in CPT management because it may cause loss of 14 to 18% of residual spontaneous growth, as revealed our experimental study. Hoare emphasized a risk of non-telescoping in case of secondary angular deformity. So we find intramedullary nails inserted through metaphysis more appropriate in comparison to transphysial rodding, telescopic rodding, because intramedullary nailing allows to avoid any injury of growth plate cartilage. Another aspect. In literature, the risk of tumorogenesis induced by BMP is controversial. Cooper et al. Reported that administration of recombinant BMP was not associated with increased risk of subsequent cancer. On the other hand, there is an impressive paper of Stabe demonstrating that those risks are not negligible. The concerns about biphosphonates are related to long cumulative half-life of biphosphonates and their possible contribution to impaired healing of fractures and osteotomies, delayed tooth eruption, and their adverse events on fetus in further pregnancy. We have few long-term follow-up data available. Hypothesizing, I suppose, once resection of pathological periosteum and hamartoma done, we have no more need of biphosphonates, but local stimulation of osteogenesis remain crucial, and intramedullary nails with osteoinductive surfaces provided. Thank you for your attention, and as conclusion we can see that in abnormal bone conditions, external fixation with hydroxyapatite coated nailing provides stability of fixation, accuracy or deformity correction related to flexibility of intramedullary nails as their osteoinductive surfaces, biological stimulation of bone formation in dysplastic zone and bone union after osteotomy. Intramedullary nails left in situ maintain medullary canal. There are no needs of resection of dysplastic bone zone, neither need of bone grafting. We did not observe migration of intramedullary implants in long-term follow-up on condition if we used hydroxyapatite coated nails, and this technique does not damage physis. Thank you for your attention again, dear colleagues.